Hi everyone, today we'll be talking about an important disorder of the fifth cranial nerve, that is trigeminal neuralgia. Okay, so before we go into the topic, a few points in epidemiology. So it's relatively common, it occurs in 4 to 8 persons per 100,000 population, and remember that it always affects females more than males. Okay, more than 60% of the trigeminal neuralgia cases occur in females. Okay, and it occurs in the elderly population. The mean age of onset is 52 to 58 years. So an important point over here is whenever you have a young patient or a patient presenting with trigeminal neuralgia less than 50 years of age, you have to rule out multiple sclerosis. Okay, so this is an important MCQ point. Next, coming to the clinical features. Okay, so you have recurrent, unilateral, severe paroxysmal lancinating and stabbing pain, usually occurring over the lips, the gum, cheek and chin, most commonly involving the second and third division of the fifth cranial nerve. Okay, so the most common division in which is involved is the maxillary division. Okay, the maxillary division is the most commonly involved. The least involved branch is the ophthalmic branch. Okay, so ophthalmic division is least involved. The most commonly involved is the maxillary division. This is an important MCQ. So like I said, the pain can be stabbing or lancinating in nature, and you have classically what is known as trigger zones. Okay, where that even a mild sensory stimulus, okay, or just a mild touch can trigger severe pain in trigeminal neuralgia. Okay, usually these trigger zones are present over the lips, face and the tongue. And the common triggering factors could be something as simple as when the patient is washing his face, brushing his teeth, or something as mild as just a draft of an air can trigger an attack in trigeminal neuralgia. And very important, your neurological examination in trigeminal neuralgia will be normal. You will not have any objective signs of sensory loss. But when you do have objective signs of sensory loss, always rule out multiple sclerosis. So as we discussed earlier in epidemiology, young patient or less than 50 years, think about multiple sclerosis, and any patient having sensory loss in the fifth cranial nerve, you should think of multiple sclerosis. Next, just a short discussion about pathology. So basically what happens is you have your large myelinated fibers. Which usually carry sensations like touch. So what happens is you have a tortuous vessel. Which is going to compress this large myelinated fiber, leading to demyelination. Okay, and then what happens is this demyelinated large fiber gets electrically coupled with the small unmyelinated fibers which are going to carry pain. Okay, so this explains the pathology behind your trigger zones, why even something like touch, a non-noxious stimulus, can trigger severe pain in trigeminal neuralgia. And the most common culprit vessel which is involved over here is the superior cerebellar artery. This is a very, very important MCQ. The superior cerebellar artery is the most common culprit vessel for trigeminal neuralgia. Rarely it can even be caused by some tortuous veins also. Now coming to the differential diagnosis, the top on the list is multiple sclerosis. So when should you doubt that a trigeminal neuralgia patient is having multiple sclerosis or it's caused because of multiple sclerosis? Number one, like I told you earlier, when the patient is going to be young or the age of onset is less than 50 years. Okay. Number two, when the trigeminal neuralgia is bilateral. Usually idiopathic trigeminal neuralgia is unilateral. So when you have bilateral trigeminal neuralgia and when you have non-paroxysmal pain. So as we discussed in the clinical features, the pain is paroxysmal, it's intermittent, it's not continuous. But when you have non-paroxysmal pain, again you have to think of MS. Okay, and next when you have sensory loss, when a neurological examination of the fifth cranial nerve is abnormal, when you have sensory loss, again more in favor of MS. So these 4 points you should remember. Okay, possible MCQ question. Next is cluster headache. Okay, sometimes cluster headache can actually be associated or it can coexist with trigeminal neuralgia. So this is what is known as cluster tic. And sometimes hemifacial spasm can occur along with trigeminal neuralgia, and this is known as tic convulsive. So this is a probable MCQ question. And I forgot to tell you that actually trigeminal neuralgia by itself is called tic doulorex. Okay, so what happens, why it's called tic doulorex is because when the patient has a severe paroxysmal pain, he's going to wince. Okay, the patient's going to have a tic or a wincing appearance. So that's why trigeminal neuralgia itself is also known as tic doulorex. Next, giant cell arteritis and aneurysm, acoustic neuroma, neurofibroma, meningioma. When any of these are going to compress the fifth cranial nerve, okay, they can cause secondary trigeminal neuralgia. Okay, when they're going to compress the trigeminal nerve. Okay, now coming to the diagnosis, usually trigeminal neuralgia is a clinical diagnosis, okay, but sometimes you have to take an MRA brain with an MRA. So you are going to take MRA brain to rule out all the differential diagnosis that we discussed earlier, aneurysm, any brain tumor, acoustic neuroma. And why we're taking MRA is preoperatively. So in case you're going to surgically manage trigeminal neuralgia, if you want to visualize the vessel where you're going to do microvascular decompression, that time preoperatively need high quality MRA images. Okay, and you can do ESR and CRP if you want to rule out giant cell arteritis. If you are having a doubt of giant cell arteritis, you can do ESR and CRP. Okay, coming to the treatment. Okay, now first you can have medical treatment and surgical treatment. So coming to medical treatment, the drug of choice is going to be carbamazepine. This is an important MCQ question. But the problem with carbamazepine is it has a lot of side effects. Okay, it can cause hyponatremia, SIADH, agranulocytosis, aplastic anemia. It has a whole wide range of side effects. So in case the side effects become problematic, you can try a similar drug, that is oxcarbazepine. Okay, it has lesser side effects compared to carbamazepine. Next, the other drugs we can use are lamotrigine, phenytoin and baclofen. But the drug of choice, remember, is carbamazepine. That's an important MCQ. Now coming to surgical management, you just have to remember this. Microvascular decompression. The surgical management of choice is microvascular decompression. It has a success rate of more than 70%. Other surgeries, if you know the name, it's enough. Okay, so you have gamma knife radiosurgery and radiofrequency thermal rhizotomy. Okay, so this is about trigeminal neuralgia, and I think there are a few important MCQ points here. So remember that trigeminal neuralgia is also known as stick dolorex, and the fact that female patients are more commonly involved, and trigger zones. You should know about trigger zones. You should know about that sensory examination is going to be normal in idiopathic trigeminal neuralgia, and superior cerebellar artery. The most common culprit vessel, superior cerebellar artery. Very, very important. Remember this point. And next, multiple sclerosis. When do you doubt multiple sclerosis as a cause of trigeminal neuralgia? That point is important. And then drug of choice, carbamazepine. Surgery of choice is microvascular decompression. Okay, thank you.